Hello everyone, today we will have a brief discussion on relapsing fever. It is a common infectious disease in developing nation, particularly the Horn of Africa is suffering from this infectious disease, and specifically our country Ethiopia is suffering from this outbreak. The reason behind this nation is suffering from frequent war, famine, drought and the like. This results in people to become homeless and additionally large number of people to reside in refuge camps. As you know, nowadays almost all refuge camps are carrying large number of people. This results in poor sanitation and overcrowding. As you know, the vector for relapsing fever is louse, so crowding and poor sanitation will promote louse infestation. So if there is louse infestation, it will result in the transmission of the borrellia species from infected person to the healthy one. Relapsing fever, as the name indicates, it is an infectious disease characterized by a relapsing pattern of fever, and this results from infection by borrellia spirochetes. This disease condition was identified by ancient Greece 2000 years back. They understood that patient presented with this specific pattern of fever, two febrile episodes which are separated by wellness. This condition was described by the ancient Greece as relapsing fever. However, they didn't understood the etiology behind this disease condition. So the etiology was described in the 19th century due to the development of microscope and other microbiological studies. They have identified the spirochetes from a blood sample taken from a patient presented with this pattern of fever, and they have identified the borrellia species. Let's come to the etiology of relapsing fever. It is caused by bacteria from the bacterial groups spirochetes because it has helical or spiral shape, and under the genus Borrella because spirochetes includes other types of infectious disease also, like Treponema pallidum, the one which is causing syphilis, leptospirosis. All these disease conditions are also caused by spirochetes, but in case of relapsing fever, it is caused by the genus Borrella. So Borrella are their thin, coiled, microscopic filaments. They are moving in one direction and they will recoil again, then they will move to the next one. So by their microscopic features, they are explained as spirochetes. Technically, they are gram-negative bacteria, but they are very small. Almost they are 30 micrometers long and 0.3 micrometer wide. So this makes it difficult to be seen under gram stain. And this bacteria has a helical shape and it has outer and inner membrane. The most important thing that we should know is the outer membrane of this bacteria is very loose, so it can be easily disrupted during histologic preparation and smear preparation for microscopy. This will give it different morphological feature. So sometimes it may confuse laboratory technicians because disruption of the membrane makes it to lose its spiral shape. And developing under culture media is very difficult. Almost a few laboratories in the world have this culture. So usually it is identified through GIMSA light stain under light microscope. Now let's discuss on the two types of relapsing fever. The first one is louse-borne relapsing fever and the second one is tick-borne relapsing fever. They are classified based on the underlying vectors transmitting the two types of relapsing fever. The first one in louse-borne relapsing fever, the vector is louse, and the second one in tick-borne relapsing fever, the vector is ticks. So the reason for classification is because the epidemiologic distribution of these two diseases are very different, and additionally it also affects our treatment duration. So what's the difference between these two? The etiologic wise, in louse-borne relapsing fever, the underlying etiology or the underlying species is Borrella recurentis. However, in tick-borne relapsing fever, there are more than 8 species of Borrella transmitted by ticks. This includes like Borrella turicate, Borrella dutoni, Borrella parkeri, and the like. When it comes to the epidemiology, the louse-borne relapsing fever has a global distribution, but nowadays it has disappeared from the most part of the world, and currently it is very abundant in developing nations, specifically the Horn of Africa. When it comes to tick-borne relapsing fever is available in every part of the world. The only part of the world immune from tick-borne relapsing fever is the Arctic one, and sometimes the tropical part, it's uncomfortable for these vectors. When it comes to the vectors transmitting the disease in tick-borne, it's louse, as the name indicates. When it comes to tick-borne relapsing fever, they are ticks. When it comes to the mode of transmission, in case of louse-borne relapsing fever, it is transmitted through crushing of the vector, which is the louse. When the louse tries to take a meal from a healthy person, and it will cause irritation. So for that reason, the person will crush the lice over the wound, so the spirochetes can easily enter into the circulation of the healthy one. When it comes to tick-borne relapsing fever, it's transmitted once the tick take a meal from the infected person. The spirochetes will enter into the tick, and it will move to the healthy one, and when it takes a meal from the healthy one and finally release its saliva on the wound, the saliva contains the spirochetes, so it can easily enter into the circulation of the healthy one. It's the same as malaria transmission. When it comes to the reservoirs of the infections, in case of louse-borne relapsing fever, human is the only reservoir. But in tick-borne relapsing fever, different mammals can be reservoirs, like rodents, like pigs, and other domestic animals. Additionally, human is also a reservoir for tick-borne relapsing fever. When it comes to the symptoms, in case of louse-borne relapsing fever, the duration of fever is very long compared to the tick-borne relapsing fever. And the remission time, which means the wellness of the person, is very long in case of louse-borne relapsing fever compared to tick-borne relapsing fever. The number of relapses are very few in case of louse-borne relapsing fever because, as I have mentioned earlier, the remission time is very long, so it will not relapse frequently. So number of relapses very few in case of louse-borne relapsing fever, but in case of tick-borne relapsing fever, there are many relapses. The reason behind this, the remission time is very short, so it will frequently relapse. For that reason, number of relapses are many. When it comes to the mortality rate, in case of louse-borne relapsing fever, without treatment, it can reach up to 70%. 7-0. When it comes to tick-borne relapsing fever, maximum up to 10%. And there is what we call vertical transmission, which means in case of louse-borne relapsing fever, there is no vertical transmission. It will not be transmitted from one lice to the next generation of lice. But in case of tick-borne relapsing fever, once the tick is infected, it will transmit to its offspring through transovarian transmission. That's why it's not disappeared even from the developed nations like America, Canada, Europe. Tick-borne relapsing fever is still available because there is transovarian transmission. Borrellia species have their own geographical destination. Each species has its own territory. But the exception is Borrellia recurentis. It is available globally, but nowadays it is confined to the Horn of Africa, and particularly in Ethiopia, it's very common. The reason behind is the presence of, as I mentioned earlier, important risk factors like famine, war, poverty, and homelessness. This results in people to reside in refuge campus, and refuge campus has poor sanitation and overcrowding, which is suitable environment for louse infestation. So the louse can easily transmit the Borrellia species from the healthy individuals to the from the infected individual to the healthy one. When it comes to tick-borne relapsing fever, it is found in most continents. There is a new species which is discovered recently, which is Borrelia miyamotoi, and it's transmitted from the mammals. Usually it is common in forest and shrubby areas, and people usually acquire this species when they go for recreation or for work. The story begins with a lice or a louse tries to take its meal from infected person. So once the louse takes the meal from infected person, the spirochetes within the blood of infected person will enter into the louse or the ticks. So once the louse moves from the infected person body to the healthy one, again it will take its meal from the healthy person, and during the time the person feels irritation. So due to the irritation, the person will crush the lice During crushing, the spirochetes will be released to the wound site, so it can easily gain access into the bloodstream, so the spirochetes will enter into the circulation. That's what we call it inoculation. So once the spirochetes are inoculated into the healthy person, they will rapidly start binary fission, and they can easily double every 6 hours. Even they can reach to the level of 1 million per ml of blood. So once this incubation period is over, usually the incubation period is 2 days up to 2 weeks. So after 2 days or after 14 days, the patient immunity in between will develop antibodies against these spirochetes. So those antibodies will come and bind to the spirochetes and try to destroy the bacteria through opsonization and bactericidal activity. This process will result in systemic inflammatory response. The systemic inflammatory response results in symptoms like fever, rigor, chills, headache, myalgia, arthralgia, and the like. So all the symptoms are resulting from our body response to the infectious bacteria. The bacteria has one special feature, that it can easily change its surface protein, lipoprotein. So this is what we call it antigenic variation. That antigenic variation will make the bacteria to be immune to the developed antibodies. So once the bacteria develop the new lipoproteins, then the older immunoglobulins will not have a response against the new one. So in between, again, our immunity will start to develop antibodies against the newly developed antigens. For that reason, during that time, the patient will become healthy because there is no immune response. So after 4 to 7 days, the newly developed immunoglobulins again will destroy the newly expressed antigens. So this response again will result in the second phase of fever. That's what we call it relapsed fever, or a fever which comes after it has disappeared. So this is the most important pathophysiology behind the pattern of the fever. So from this we can conclude that the number of relapses is directly proportional to the number of antigenic variation. So if the bacteria changes its antigen 10 times, then the patient will have 10 relapse. If it has 3 antigenic variation, the patient will have 3 relapses. So during the inflammatory response, there will be a time of crisis, the point where there will be maximum destruction of the bacteria, and during the time the patient will develop fever, hypotension, and other signs of shock. This immune response is the same as JHR. We will discuss JHR by the end of our presentation. Now let's discuss on how the patient developed the following symptoms. In relapsing fever, the first one is hepatosplenomegaly is very common. The reason behind this, the spirochete will bind to the red blood cells. So the red blood cells will form aggregation of red blood cells. So once they are aggregated, they cannot easily squeeze out of the spleen. So they will be trapped in the spleen. This will result in tender splenomegaly. The same will happen to the liver. Sometimes they are also associated with hepatitis. For that reason, hepatosplenomegaly is also a common feature. It is one of the differential diagnoses for a patient presented with hepatosplenomegaly. The second one is anemia. The cause of the anemia is because of aggregations of the red blood cells within the spleen. For that reason, patients will develop mild to moderate anemia. The third thing is bleeding disorders. Why they do develop bleeding disorder is because, as I've mentioned earlier, the spirochetes will bind to the red blood cells. The red blood cells will form aggregations. So once they are aggregated, they will occlude small blood vessels. If there is small blood vessel occlusion, the one which we call it disseminated intravascular coagulation will happen. So the platelets will be consumed by this coagulation. So it will result in thrombocytopenia. Additionally, the liver is also affected. So clotting factors will not be adequately produced by the liver. That will result in deficiency of clotting factors. Additionally, the clotting factors also consumed within the DIC. So due to this combined effects, thrombocytopenia, deficiency of the clotting factors, will result in bleeding disorder. So patient may have bleeding from the nose, or patient may have hematemesis, petechial rash, ecchymosis, and the like. When the Borrielia species invade the CNS, the central nervous system, patient may develop features of meningoencephalitis. In this scenario, we may need to do lumbar puncture and do CSF analysis, and sometimes it can be demonstrated under microscope from this CSF analysis. And when a pregnant mother is infected by Borrielia species, it can cross the feto-maternal barrier, so it can result in placental damage. Whenever there is placental damage, always we will suspect IUGR, intrauterine growth restriction, and if the pregnancy is early, there is a possibility of abortion. Now let's discuss on how to approach a patient presented with relapsing fever. The first and most important part is history. Under history, the most important history is the fever pattern. So we need to describe the pattern of the fever. Whenever a patient presented with fever, then we need to ask him the duration of the fever, if there is any wellness between the fever. So the most important thing is the one which I have mentioned earlier. The patient will have fever for 1 up to 3 days. Then he will be fine for 4 up to 7 days. Then the fever will begin after 7 days. So this is a specific pattern of relapsing fever. Whenever the patient is febrile, it will end up with crisis. The last stage of the fever will result in crisis which lasts for 30 minutes. The time of crisis is characterized by high-grade fever, rigor, tachycardia, hypertension, and immediately it will be followed by profuse diaphoresis, hypothermia, hypotension, bradycardia, myalgia, and prostration. Additionally, the patient may have non-specific symptoms of febrileness like headache, arthralgia, myalgia, and the like. And due to the hepatosplenomegaly and hepatitis, patient may have abdominal pain, vomiting, and nausea, and the like. And occasionally, in case of louse-borne relapsing fever, patient may have non-productive cough because of the bronchopneumonia, and in rare case, patient may develop ARDS. The second most important history is risk identification. Usually, these patients came from either from refuge camp or from prison, because these two environments are highly characterized by poor sanitation and overcrowding. So these two important history may lead us to diagnosis of relapsing fever. After taking history, we need to do physical examination. Under physical examination, on general appearance, patient might become delirious. Sometimes he can be comatose, and usually these patients have poor grooming, which means they are not hygienic. So from this even we can suspect the presence of relapsing fever. Then we need to take the vital signs. Patient blood pressure can be hypotensive, but in the time of crisis, patient might become hypertensive. Pulse rate, patient become tachycardic. In case of respiratory rate, they are tachypneic, and fever is the most important objective data. They may have as high as 41 degrees Celsius. And saturation is important because patient may develop ARDS or bronchopneumonia. Then on HANT, patient may have epistaxis. The reason behind this, the presence of bleeding diathesis in case of relapsing fever. Then on cardiovascular system, Borrielia can cause myocarditis. So myocarditis might be characterized by the presence of gallop rhythm. On abdomen, we can identify hepatosplenomegaly. Under integumentary system, patient may have ecchymosis and petechial rash. On central nervous system, patient may have altered mentation. Additionally, he might be disoriented. And the other important thing is we need to assess the cranial nerves. Patient may develop Bell's palsy, blindness, deafness, and the like. After doing physical examination, the most important diagnostic tool is microscopy. So under light microscope, laboratory technicians use Jim-Sarite stain, the one which they use it for plasmodium identification. So under microscope they will see spiral shaped organism. So by this way we can confirm the diagnosis. We shouldn't forget that the sample should be taken at the time of fever, that when the patient is febrile. The reason behind it, the spirochetes is available in the blood during the time of fever. Otherwise we cannot isolate or identify the bacteria. Additionally, dark field microscope might be also helpful, and other investigations are for assessing the presence of complications like CBC. Under CBC, on WBC series usually it's not affected. On red blood cell, patient may have mild to moderate anemia. On platelet, patient may have thrombocytopenia, so we need to send CBC. The other thing is CRP and ASR might be raised because they are inflammatory markers, and we need to do liver function tests, and liver enzymes might be elevated. Additionally, unconjugated bilirubin might be high. The reason behind is poorly functioning liver. And coagulation profile is very important because of consumption coagulopathy. We need PTT might be prolonged. ECG is important because, as I have mentioned earlier, myocarditis can be caused by the Borrellia species, and prolongation of QT interval is typical finding. And additionally, CSF analysis is done for patients with evidence of meningoencephalitis, and PCR and culture usually they are not used for diagnostic purpose. The differential diagnosis for relapsing fever includes like malaria, typhoid fever, typhus, brucellosis, dengue fever, leptospirosis, and other febrile illness can be the differential diagnosis. But we can differentiate from all these febrile illness by the pattern of the fever. The most important thing is we need to characterize the relapsing pattern of the fever. One. The second one is history of recent exposure to lice or ticks. Usually in case of louse or relapsing fever, the patient may come from prison or refuge camp. So if you get these two evidence, then I need to send microscopy examination. Under microscope it can be confirmed. Now we have already diagnosed relapsing fever. So how do we manage patients diagnosed with relapsing fever? There are three management principles. The first one is drug treatment. We need to give him antibiotics. I will show you which antibiotics are used. Then we need to treatment complications. After giving antibiotics, the patient will be in crisis. So during that crisis time, we need to support the patient. Finally, delousing. So in order to avoid recurrence, immediately the patient should be taken to isolation room, and he should remove his clothing and change the new one, and he need to clean his body. With this way we can do, and we need to give different types of cream in order to treat the louse infestation. So the most important thing in the management is continuous monitoring of vital signs, especially for the first 3 hours of after giving antibiotics is mandatory, because it is the time where the patient will develop JHR, Jarisch-Herxeimer reaction, and the patient can be kept for 24 hours and we can discharge him with pure medication, because after 24 hours the risk of JHR is very low. So immediately we need to secure IV line, because after administration of the antibiotics the patient may develop shock. So securing IV line by the time might be difficult, so we need to insert IV cannula by the time of admission. Then we need to control the temperature with antipyretics. Then we need to start antibiotics. So the choice of antibiotics are penicillin and tetracycline. These two drugs are very potent for Borrellia species. As an option, erythromycin, chloramphenicol can be used, and we can also use second and third generation cephalosporins are also effective. Antibiotics, especially when we are working in resource limited area, we can give a single dose of antibiotics for treatment of relapsing fever. We can give single dose of tetracycline for adult 500 mg Piostat, for children 12.5 mg per kg Piostat. But this drug class is not used for pregnant lady as well as for children less than 8 years old. As an option, we can use also doxycycline 200 milligram pyostat, or we can give procaine penicillin 800,000 international unit IM stat, or we can also give erythromycin 500 milligram pyostat. These are options of management. The most important problem in single dose treatment or therapy is the recurrence rate is as high as 20%. In optimal condition, we need to continue the treatment for at least 1 week. This is treatment algorithm taken from Harrison 21st edition. In case of louse relapsing fever with no any CNS sequelae, or if the patient doesn't develop any CNS feature, the first choice of drug is giving single dose of penicillin G 800,000 international unit IM stat. Then after 12 hours we can start PO medication doxycycline 100 milligram BID for 1 week. So this is more than enough treatment for a patient presented with relapsing fever. As a second line drug, we can use erythromycin 500 milligram QID for 7 days, especially for patients with penicillin allergy. And as it is also an option of drug for children less than 8 years of age and for pregnant ladies. But if the patient develops meningitis or encephalitis, the first line treatment is giving ceftriaxone 2 gram daily for 2 weeks. In case of tick-borne relapsing fever, the management is the same, but the duration is for 10 days. In case of louse-borne, it is for 7 days. So what's JHR, Jarisch-Herxeimer reaction? It is a reaction which results with initiation of antibiotics. It is clear. Once you administer the antibiotics will begin to destroy the spirochetes. So the release of different endotoxins from the spirochetes will induce the immunity and to release different chemokines, cytokines, and different immunologic responses. All these conditions will result in high-grade fever, and it will result in vasodilation, and patient will pass through 2 phases. So the first one is chills phase, where the patient will have rigors, rising blood pressure, tachycardia and tachypnea and the like. Immediately he will have flash phase, which is associated with hypotension, and usually it may last up to 24 hours. It is the same as septic shock. So JHR is in Jarisch-Herxeimer reaction results from destruction of the spirochetes by antibiotics. The risk of JHR is about 20 to 60% in louse relapsing fever. Sometimes in some data says up to 90% of a patient may develop JHR from louse relapsing fever. And the risk is very high with management of a patient with tetracycline. That's why we don't start with tetracycline. Rather, we give procaine penicillin for the first 12 hours. Then after 12 hours, we will initiate tetracycline, because it will decrease the risk of JHR. The cause of JHR is not only management of borrellia. It can also result from management of syphilis. When you give benzathine penicillin for management of syphilis, patient may develop JHR, but it is milder, and even the risk of occurrence is low. Sometimes JHR can also develop with suboptimal treatment of relapsing fever. Sometimes we physicians wrongly diagnose relapsing fever for other types of febrile illness, for example typhoid, and we may give him the ciprofloxacin. Ciprofloxacin is inadequate or suboptimal treatment for Borrellia species. This may cause JHR on the patient. So the most important thing for management of JHR is fluid administration. Whenever the patient becomes hypotensive, we will give him bolus of fluid. We can give NS, we can give ringer lactate. 250 ml bolus can be given, but when we give a fluid, we need to follow the urine output and features of pulmonary edema. Otherwise, there is no need of giving corticosteroids. There is no need of giving any other additional antibiotics, because the JHR results from the antibiotic response. So for that reason, the only thing is we need to provide the patient with fluid support. When it comes to the prognosis of relapsing fever, for untreated louse relapsing fever, the mortality rate can be as high as 70%, in tick-borne about 10%. With treatment, it is about 5% for louse relapsing fever, and it's less than 2% in case of tick-borne relapsing fever. However, the mortality rate is largely determined by presence of coexisting conditions like malnutrition, other febrile infections like typhus, malaria, typhoid, and additional dehydration. Poor prognostic factors are when a patient has features of bleeding disorders, features of CNS infection or meningitis, when a patient is malnourished, when there is concomitant febrile illness like malaria, typhoid, typhus. These are important poor prognostic factors. In case of pregnancy, it may result in abortion or stillbirth, but there is no evidence for congenital malformations. Prevention of relapsing fever. There is no vaccination for this disease. In order to prevent relapsing fever, we need to prevent ourselves from louse or the vector. So in order to eliminate the vector, the most important thing is avoiding overcrowding and good sanitation, and we need to clean the infected clothes with hot water. With this way, it can be prevented. And in tick-borne relapsing fever, avoiding rodents and building a house with concrete may help people to decrease the risk of tick-borne relapsing fever. In case of post-exposure, we can use post-exposure antibiotics prophylaxis. For exposed individuals, doxycycline 200 mg on day 1, and we can continue 100 mg daily for 4 days. This is a prophylaxis for relapsing fever whenever we feel we are exposed to the borrellia species. These are the reference books that I have used in order to prepare this presentation: Harrison 21st edition, Nelson 21st edition, Management Guideline of Ethiopia 2020, Pediatrics Management Guideline 2016, up to date, Medscape CDC Guideline for relapsing fever. All these books are used in order to develop this presentation. Thank you for your attention.